Please, Dr. Basa. He is a consultant pediatric nephrologist at Al Hospital. He has finished his MD from Damascus University, Syria, and GIS in pediatrics from Paris 5 University. He has done his DIU in pediatric nephrology from Claude Bernard University in Lyon, France. He has a fellowship from the Honorary Fellowship from Edinburgh. He is a consultant pediatric nephrologist with us and is also the chairman of Pediatric Nephrology Fellowship Program in Syria. He is the president of the Farah Association of Children with Kidney Disease in Syria. He is also the president-elect of the Middle East Society for Organ Transplant. He is very active in research and academic activities along with our clinical activities. It's a pleasure to have Dr. Bassam with us.
Much. Good afternoon. Sorry for starting just after the lunch. I know that before lunch everyone is having hypoglycemia, and hypoglycemia increases the alertness, so everyone will be alert, but after lunch I think the opposite is true. So we have three lecturers in this session, three topics. The first topic is urinary tract infection and update. Our first speaker is Dr. Ihab Shaheen. Dr. Ihab Shaheen is trained in pediatrics from London. He's consultant pediatric nephrologist in Dubai, United Arab Emirates. He has a long experience in pediatric and pediatric nephrology as well for 24 years, and working in different centers, 4 centers actually: Egypt, Kuwait, United Kingdom, and recently Dubai. So please, Dr. Ihab.
Good afternoon, everyone. It's a great pleasure to be here, especially when you give a lecture amongst faces that you know, faces that you've worked with for a long time. I have the pleasure of working in Kuwait in the late 90s, and it's a pleasure to invite me, Fahd, to this conference, which is very successful. I actually was talking to my colleague in Glasgow, James, and we're gonna copy this conference for GPs and general pediatrician mostly in a year or two, because I think it will add too much. The problem I have is I'm giving my lecture immediately after lunch, which means you are sleepy, you're tired, you've been to a very tough day. So I will try to be short. Unfortunately, I cannot move. Usually nephrologists are a bit autistic, they move too much, thinking, or I don't know, but I can't move. They keep me standing here, so I'll try to keep moving. The whole idea about this conference over the past 2 days, my understanding is actually to give you a feel of the common diseases, rather than give you complex stuff that you may or may not see. So let me start, and please interrupt me at any time. I'll try to keep up with time, because I've seen my colleagues struggled a bit with the time. So first, relax. This is very nice part in Glasgow. It's a lake called Loch Lomond, which is very nice spot for you who would come and visit. You will enjoy looking in this lake, with lots of ideas about monsters living there and all this stuff. So I will start by why UTI, and then I'm gonna test. Then I'm gonna test actually how did you absorb the lectures yesterday. I think you have a lecture from Anna. Unfortunately, she's still eating. So Anna told you yesterday you have to remember it cries. And Fahd, Dr. Fahd, when he started the opening ceremony, he was explaining why we are doing this, why we need to get people to know how to actually practice common diseases in more sort of evidence-based. And Dr. Fahd gave you an example of this child who is having pain while micturition, and then the doctor came to A&E, and the doctor gave him antibiotics. No history, nothing what happened. So that's why UTI is very important. It's a common disease. And you have to remember it cries from Anna Jarv's lecture yesterday, because she emphasized that it I means infection, and if you remember the first in between brackets was urinary tract infection as a missed diagnosis, especially in young children. So UTI has been always a debate. Usually when you go to pediatric nephrology conferences, they will have a debate between someone who doesn't like to do investigation versus another nephrologist who like to do more. But the reason behind this is most of UTI in the past 50 years or so has been aggressively investigated. I'm not gonna tell you today more about recurrent sort of UTI. Maybe I'll touch base on it, but mainly I will focus on first febrile UTI in children dying age. So if my objective today is to tell you about how to investigate the first febrile urinary tract infection, this would be enough for the day. So you can go home now. Okay, so just stay with me. The main thing is I don't want you to take too much from the lecture. You will find me actually running through slides a bit quicker than other slides, which means that this is the point that I would like to focus on. So the reason behind it is there was always, I've been trained in nephrology as always, vascular-ureteric reflux is bad. Vascular-ureteric reflux makes you getting recurrent infection because then it goes back to the kidney. And so I have to give you prophylaxis antibiotic from your first urinary tract infection. Why, doctor? Because your kidney is gonna get a scar and you're gonna get impaired kidney function. You're gonna stay on dialysis and you will take your mommy or daddy kidneys. So this was the concept, and the doctors, the nephrologist was saying when you have a scarred kidney, your blood pressure goes high and the protein in the urine is getting more and you will develop renal failure. So this was the whole rationale why we have taught years and years. This is the whole story of vascular-ureteric reflux. My aim, again, I'm gonna keep repeating it. No, this is not true. And this is the change which has been happening over the past 20 years or so. So aggressive radiological investigation and prophylaxis antibiotic use following urinary tract infection has been the mainstay in clinical practice for almost 50 years or so. So my objectives, don't worry, I'm not gonna tell you too much about this. As I said, my focus is first febrile urinary tract infection. So the prevalence of UTI in recent meta-analysis in the States, they found in 14 studies that the prevalence is almost 5%. It's quite a common disease for children up to the age of 2 years old without an obvious source of infection. Diagnosis, as you have heard from Anna Jarvis yesterday, it's a challenging diagnosis. Neonate present with fever, vomiting, failure to thrive. Any child younger than 3 months with pyrexia, I would recommend more than 38 without any focus. You have to check for urinary tract infection. Older children with secondary wetting is a red flag always. Secondary wetting in pediatrics is a red flag. You have to search for it, whether diabetes, whether it's social circumstances changes, abuse, but you have to think, or of course the commonest reason in older children will be urinary tract infection. In small children, always try to obtain urine sample with suprapubic aspiration or bladder catheterization. This is the latest recommendation from both the National Institute of Clinical Excellence in the UK and from the American Academy of Pediatrics, if possible. If this is not possible, keep in mind the high risk, of course, of contamination. I'm sure all of you who looked after children, they will have most of urine cultures coming as contaminated growth or the numbers that you're not used to and you don't know, am I gonna treat or not. A bacterial count of more than 10 to the power 5 is useful to define urinary tract infection, but a proportion of true infection have lower bacterial numbers, especially with different collecting methods. To simplify, if you have suprapubic aspiration and you find bacteria, you most likely will have urinary tract infection. If you have a urine bag or urine pad, like what we used to do in the UK, and the number is not that significant, most likely it's contamination. Again, urine dipstick, leukocyturia, and positive nitrite. Leukocyturia always indicate pyuria, which can happen in febrile children in general. But if you combine, my advice, if you combine both leukocytes or white blood cells in urine dip, along with the nitrite being positive, which indicates that the bacteria is transforming nitrate into nitrite, this could be a good indicator for you. Always aim to make a level of diagnosis, i.e. the child is unwell with fever, you're not sure what's going on, you may think about LP, you're not sure about, or it's just you're talking about cystitis or lower urinary tract manifestation or asymptomatic bacteriuria, which I am not interested to treat. So, as we have Dr. Bassam as a surgeon of vasculoenteric reflux, with my urology colleagues, this is always a point of discussion. So I'm going to give you a hint, which is my main idea today, to stop people trying to find vasculoenteric reflux. In simple febrile urinary tract infection, vasculoenteric reflux, to find it even up to grade 4 or whatever, is not something you should panic about. I'll try to convince you, even after your tummy is full, that this is the right thing to do. Right. How common vasculoenteric reflux? All chimpanzees have vasculoenteric reflux. You don't see chimpanzees having scarred kidney or so. They grow out of it. 10% of dogs, rats, rabbits, all of these, they are all born with vasculoenteric reflux. What about human? It will be unethically to try to get a normal child and try to get a normal child MCUG or micturating cyst ureterogram to try to see if they've got reflux or not. However, I don't know how they managed to skip the ethical approval in the 50s and 60s. They have up to 25% in human could have vasculoenteric reflux, unknown, undiagnosed, not causing any harm. Of course, the data of prevalence among normal children will not be existing. Natural history of vasculoenteric reflux from different studies and from recent technical report from the States and the NICE guidelines, which I have reviewed along with my colleagues in 2013 in October, we found that natural history of vasculoenteric reflux, 1, 2, 3 spontaneous resolution as at 13% per month. Even more, the resolution in 2.4 years follow-up of these kids, grade 1, 92% they will disappear, grade 2, 76%, even dilating 3 or 5, in 10 years follow-up, 3/4 of them disappear or change to grade 1. So, first febrile urinary tract infection, don't get excited to diagnose vasculoenteric reflux if the ultrasound scan is normal, which this message I'm gonna keep repeating till I'll try to convince you this is the right thing to do. So it's a physiological finding which disappears as the child grows, as a simple case of, or simple febrile urinary tract infection. I'm not talking in this topic about cases with posterior cerebral valve, cases with sibling with urinary tract infection and scarred kidney, case of poor urinary stream, spina bifida. I'm talking about the simple ones that you would see more commonly even primary health care or as a general pediatrician. Chand in Journal of Urology in 23 has proven that as prevalence of vasculoenteric reflux in children after the first urinary tract infection, as you can see even from 35%, they go down over the years to decline very, very significantly. So why are you interested to diagnose this at that early stage if they're gonna grow out of it? More importantly, what I've learned through the years, how much radiation we're giving to the children. Research has shown that if you smoke X number of cigarettes or whatever in years, maybe you're gonna develop cancer or something like this later on. But more importantly, some group of people started to say, what about radiation? When you have a child, a chest X-ray, it gives them this millisievert of 0.03 as a chest X-ray. Average, depending on where you work, depending on your radiologist, average of micturating cyst ureterogram or DMSA is almost, you're doing 50 X-ray in one go. So as if you have a child standing, shoot them with beam of rays, 50 in one go. Would you like your child to be exposed to this for a simple first urinary tract infection with no high risk, with no problems? Definitely not. So now, I hope we agree that vasculoenteric reflux is not something you should look for after the first febrile urinary tract infection with normal ultrasound scan. And this will come back when I review with you the American Academy of Pediatrics and the NICE in the UK guidelines. So, okay, what about antibiotics? We doctors, we like to give instruction to the patient. Even yesterday, as we were discussing with Dr. Mohammed Hidayah, I think vitamin D, and they said, what about compliance? We always like to say to the patient, okay, you don't take the prophylaxis antibiotic, you're gonna get infection. This is really not true at all. Prophylaxis antibiotic has not proven to do this, because a recent Maria from the States in the technical report reviewed prophylaxis antibiotic prevention from children without vesicular reflux. And as you see, this diamond black touching 1, which means that the confidence interval touching 1, which means that it's not significant. So any child with, without vesicular reflux will not have. Of course, you will tell me, but this doesn't have vesicular reflux. What about the others? What about the recurrence of pyelonephritis or febrile UTI among children at this age with vesicular reflux, any grade, with or without use of antibiotics? No significance. So there was no significant difference in the rate of recurrence pyelonephritis for children 2 to 24 months with vesicular reflux of any grade or without vesicular reflux. Received antimicrobial agent versus the one who have not received antibiotic prophylaxis. What about, with our surgeon, what about the surgical intervention? My practice with my urology colleagues back in Glasgow is we don't usually touch these children for any deflux mechanism, which is trying to stop via cystoscopy to try to stop the vesicular reflux. We only do this in girls above 1 year because it has shown to decrease the number of febrile UTI, but not the cystitis. So it was actually meta-analysis of only 4 studies done, and this has shown that only the girls who will get benefit from deflux or from interventional of vesicular reflux after the age of 1, but not to prevent cystitis, only to prevent febrile urinary tract infection. Long-term sequelae, we are missing longitudinal section, so I can't comment on this after the first urinary tract infection. You can see it in red, because I'm sure lots of people will say, this is not right, because they're getting scars, they're getting proteinuria. Yes, we know, but I'm talking about why you want to diagnose vesicular reflux after the first urinary tract infection in a normal ultrasound scan. So this is the American, first time UTI. You do ultrasound, yes, you do MCUG, consider if ultrasound is abnormal. The American a bit of contradictory here in the States because they advise do it in grade 5. What I'm doing if there is any high risk, which I'm gonna tell you in a second. This is in the UK in October 2013, started in 2006, then revised again by all centers in Britain, and as you can see, all age less than 6 months up to 3 years, you can see all the red, no, you don't do really anything except if there is a typical infection or a high risk group.
Sorry, 1 minute, huh?
Sure. This is what I would like to see, like a decline of MCG result. I've collected this data over 3 years post-NICE guidelines to try to see what happens if you have a normal ultrasound scan. As you can see, what about your MCG? What you're gonna miss? The abnormal MCG in normal ultrasound was 18%, all of them reflux. One case, suspected posterior visceral valve, the surgeon went inside, it's not a valve, it's an error in MCG. So no diagnosis, no treatment. Where we should shift our focus, the high-risk group. So in any history of urinary tract infection, this is what you should do. Take the history of Puri stream, antenatal, abnormal ultrasound. What I found in these cases after, we have a database of almost 10,000 cases. What I found in these cases that they develop actually scar, no relation at all of vesicular reflux, but more in family history of vesicular reflux or scarred kidney. Again, dysfunctional voiding, enlarged bladder, spina bifida. So my recommendation will be is any child who would come with first febrile urinary tract infection at young age, do ultrasound scan. If the ultrasound scan is normal and you don't have any high risk, you sit tight, do nothing. I wouldn't go through this, but I would like to tell you whatever algorithm you're gonna follow, it doesn't matter, but try to be more towards the patient itself. Stay more time with the patient. There is nothing like the example when Fahd said that this cystitis is going, I was trying to present or show you a case. It will take a second. Like this case, 8-year-old girl, which I've seen and I've learned from her. She used to come with contaminated urine, dysuria, pain while micturition. It was all vulvitis. And this girl have a very interesting condition called urethrovaginal reflux. Urethrovaginal reflux is common, up to 15-20% age girl between 8 to 12. It's very interesting with the computers and laptop. They sit in the toilet, they look at this, urethra, vagina, urine come, go back to the vagina, they stand, start to walk, drops of urine stay, whether it's massive enough to alert the parent or stay there around the labia minora, labia majora, itching all the time, contaminated. If you only sit down and say when exactly the wetting is happening, characteristic after they come out of the toilet. So children who wet themselves after they come out of the toilet, even few drops, if they have itching, you have to be careful of the commonest cause of not cystitis, but actually vulvitis, rather than anything. And thank you very much, and I'm happy to take questions.
Thank you very much for raising the importance of this issue, when to diagnose, or when it is important to diagnose reflux in those patients with UTI, and how beneficial it is to have this diagnosis. Since the available treatment, whether prophylaxis or surgery, has little effect, except in few patients. The floor now is open for questions. We can, maybe the time may allow us for a couple of questions, because we are running late, I think, this session. Any question? If there is no right away question, I can ask regarding the X-ray exposition. You said that one of the, of course, disadvantage is to expose the children to X-rays. For some, we may diagnose the VUR if we inject galactose into the bladder. Yes. And then by ultrasound, we can see the galactose, the material, refluxing. So what do you think? Do you have experience?
Yes, yes. In Glasgow, this was another message, is always talk to the surgeon and the urologist. You don't usually work in a center where there is a pediatric radiologist. You need to know their abilities, what they can really interpret it. Most of MCUG I've reviewed, 160 plus, lots of them wasn't taken properly with a technician. You need to know how they're doing it. For the direct, indirect cystourethrogram, you need a child to be toilet trained, because they need to hold and keep this one. In where I'm working, we're doing this in Edinburgh, but not in Glasgow, because the radiologists there believe in this more than MCUG. So this is the question.
Thank you for the nice lecture, and I would like to ask you about the prophylactic antibiotic.
Yes.
Still you are using antibiotic as a prophylaxis, and actually we are seeing better clinical results than people who are not using the prophylaxis.
Yes.
So please, you can explain for me.
Yes, yes. If you're gonna use prophylaxis antibiotic, talk to the microbiology lab. Reason, the resistance index for antibiotics is the curve is amazing. You will end up, which I'm seeing over the last 2 months in Dubai, all the urine culture coming ASBL all need meropenem, because they have used antibiotics aggressively all the way through. So what you need to do is to be selective to who need the antibiotics. The one who will be high risk, the one who has a sibling with a scar, the one who, if for example, toilet trained, voiding dysfunction with computer games, in my experience, is massive. You cannot believe, if you scan the bladder after a child goes to the toilet, they can pee 10 ml and keep the rest in their bladder because they want to carry on with the computer games. It's amazing what they are doing. They can actually hold, you want quickly to go back from the anxiety, and they can still, eventually, this causes what we call it dysfunctional voiding. The synergia between the bladder and the relaxation is gone. And this is really difficult to treat. So my advice, stay with the patient more. If you're gonna use antibiotics, ask the lab, what are we doing with trimethoprim, nitrofurantoin, augmentin, because they may, actually, it doesn't take too much if you meet them. Even what we used to do is we meet them twice a year, and then they give us like tiny report about don't use trimethoprim for the timing, because actually the resistance has been quite increased over the last. So I start to swap them to nitrofurantoin and so.
Okay. Thank you very much, Dr. Ihab. Thank you.